In this video, we're going to talk to you about how to insert a nasopharyngeal airway into a patient who may require it. So all the equipment that you will need is water-soluble lubricant, the nasopharyngeal airway, and some gloves. Why would you want to insert an nasopharyngeal airway? It's usually done for a patient whose level of consciousness has decreased, and if we are worried about the integrity of their airway. So, for example, the airway collapsing, the tongue rolling back, or the patient's airway being occluded by secretions. A classic example of this would be a patient who has had a seizure and who has secretions in their mouth, and we are worried that we might have to ventilate this patient or start bagging this patient, and we are worried that their airway will close up before we're able to secure a more permanent airway. So this type of airway is temporary only until a more permanent airway can be secured or until the patient gets better within a short amount of time. So before I start, what we need to do is we need to figure out what is the right size of nasopharyngeal airway is for your patient. What's most important here is the length of your tube rather than the diameter. The diameter will depend more on the size of the patient's narines, but the length of the tube is very important because a tube that is not long enough or that is too short will actually only obstruct your airway rather than helping you secure it. So what we're going to do is we're going to take a tube, we're going to take our gloves, and to see what size you need, you will have to measure from the tip of the nose all the way to the tragus of the ear. So I will show you how this is done. I have approximated the length of the tube and I hope it will fit for this patient. So we will go from the tip all the way to the tragus, and you will see that this one is actually a little bit too short, right? So it needs to reach all the way to here, so this airway is not long enough for this patient. So I would go and I would grab another one. Now I have an airway that is the right size for my patient. I have measured from the tip of my nose to the tragus of the ear, and I'm certain that it will fit the patient. What I will do next is I will open the sterile package. This procedure does not need to be sterile. I'm wearing regular gloves, but it needs to be clean. I'm going to very generously apply lubricant to the airway. And it's an option that some hospitals have. You might even have a lubricant that contains a local anesthetic and a little bit of epinephrine in it to prevent a nosebleed. Now, before I start inserting this airway, I need to do a mental check. A patient who has a basilar skull fracture or a suspected basilar skull fracture cannot have this airway. So are patients who have faced trauma, patients who have a higher risk of a nosebleed or epistaxis, and patients who are on anticoagulant therapy. Now, with anticoagulant therapy, it has to be a decision whether or not you put it in. That's done with a doctor because sometimes preserving the airway is a lot more important. So this is something you would just let the doctor know. So now that I've done my checks, I've identified the patient, and I know that the patient needs the airway because their level of consciousness is decreased, and I'm worried that their airway might collapse. I'm going to insert this. Most of the airways are actually made to be inserted into the right narine. If you have to insert it into the left side, you just have to adjust the bevel. Before I insert it, I will check the patient's nose and I will look to see whether or not there are any obstructions that are visible to the eye. I will also, because I'm going to proceed with the insertion into the right narine, I will make sure that it's patent by covering the other side of the nose and making sure that I can feel the breath coming out. So I've made sure it's patent. I know that it looks fairly straight and I don't see any obstructions visible to the eye. I will start inserting the airway very gently, bevel to the side of the nose. So while you're doing this, the patient has to be flat on their back or possibly in the high Fowler's, but they should not be sitting up. Also, if your patient has a decreased level of consciousness, sitting up is not the best position for them. So I will insert very gently, and it's a very easy insertion. However, you might encounter a little bit of resistance. If that happens, you can rotate the tube just a little bit and continue applying very gentle pressure. If you keep encountering resistance, you have to remove the tube and try in the other naring. For me, the insertion is very easy. I went bevel to the patient's nose. The insertion is smooth and I don't feel any resistance. So I will very gently go all the way until the phalange of my airway is resting right against the patient's nose. Now, to check my placement, what I'm going to do is I'm going to try to feel whether or not the patient is actually able to expire air through this naring. And if I feel air, that's great. I'm also going to look in the patient's mouth, and what I should see is the tube, the tip of the tube right beside the patient's uvula in the posterior pharynx. So I see the tube, the tip of the tube, so my placement is confirmed and correct. And what I will do next is I will, if needed, ventilate the patient with an bag valve mask. So I have just inserted a nasopharyngeal airway, and I've checked the placement of the airway by checking whether or not I can feel the expired air through the nose. And I also checked in the patient's mouth if I can see the tip of the airway right beside the patient's uvula, right in the back of it. So now what I'm going to do is I'm going to try to ventilate this patient with an ambu bag. I've plugged it into the oxygen. I'm going to wait to make sure this bag inflates, and then I'm going to ventilate the patient and make sure that I do not feel any resistance. And I'm observing for chest inflation, and no, I do not have any resistance.